So, vamos a continuar con la siguiente ponencia, que un año más tenemos el gusto enorme de tener aquí. Is it working? Yes. Funciona, ¿no? Me dicen que es que yo hablo bajito. Tenemos el gusto enorme de contar con los doctores Stephen Wolf, que es director del Departamento de Epilepsia Pediátrica, y la doctora en enfermería Patricia McGoldrick, que están ambos en el programa del Hospital Boston de Nueva York y Connecticut para, todas estas cosas que pone aquí, que es el hospital donde ellos están. Es un hospital de referencia en epilepsia en Nueva York. Son grandes conocedores de la epilepsia infantil y tienen muchas cosas que contarnos. So I was saying that you are very welcome once again, and it's a great pleasure for us to have you here today. And I was saying that you are the director of the pediatric epilepsy department at Boston Children's Hospital in New York, and you are the whatever? No, you are nurse director of pediatric epilepsy in the same hospital, and we are willing to hear you and to learn from you as usual. So thank you for coming again.
Thank you.
Thank you. Thank you all for coming today, and thank you again to the Foundation for inviting us to speak. These are our disclosures, none of which have any, they do. This was sponsored by Jazz, and before that by Lundbeck. I can see it here. All right, so we are going to speak together, which may be different. So I'll start, and then Steve will jump in, and we'll sort of go back and forth. And if you don't understand anything, have us stop, and we'll attempt to translate. So I'm going to start first about Lennox Gastaut syndrome. The previous speakers have been talking about the genetic bases of some of these developmental delays, so epilepsy and developmental abnormalities. And Lennox Gastaut is a syndrome. It's a developmental epileptic encephalopathy. So it's not just the seizures that we talk about in Lennox Gastaut. There are many different reasons that a child can be diagnosed with Lennox Gastaut syndrome. So many of the reasons are genetic, and I will talk about that. But it is a syndrome, so there are a bunch of different causes, but the reason for identifying it is so that we can have newer treatment options, and so that these children, and later when they're adults, get the appropriate therapies and instruction in school. So Lennox Gastaut syndrome is typically diagnosed between the ages of 2 and 8. It often follows a diagnosis of infantile spasms. Am I loud enough? Because I can be louder. Okay, I'm going to be much louder. Better in the back? You can hear me, okay. My husband always says that I don't speak loud enough, and so does my partner here, but I never believe them. So infantile spasms is a type of epilepsy that's diagnosed in infancy, so in between the ages of 3 months and 10 or 11 months. And these children will present with these sort of head drop movements. It's often mistaken for a gastrointestinal problem, and it's important that it be diagnosed right away. After they've been diagnosed with the infantile spasms, it generally evolves into something called Lennox Gastaut syndrome. And the way that Lennox Gastaut is identified is they have specific seizure activity, a bunch of different kinds of seizures. They have a developmental delay, and they have a specific change in their EEG. So when we talk about developmental epileptic encephalopathies, which is something that you don't want your child to have, you have to look at the whole picture. So it's not just that the EEG is abnormal at the time that they're having a seizure, it is abnormal at all times. It's slower than usual. All right, so what we did is we looked back at the progression from childhood to adulthood. So most people who are diagnosed in childhood with Lennox Gastaut syndrome continue to have that diagnosis as they become adults. In children, they have multiple seizure types, and we're going to show you videos of these seizures. So they will have generalized seizures, they can drop, they can have stiffening, they can have the big generalized tonic-clonic seizures that we all think of as seizures. At the same time, they have an abnormal EEG or electroencephalogram. So the electroencephalogram in childhood shows a 3 hertz slow spike and wave. And we'll show you a picture of that. And they also have a developmental delay. Now, when they get to be adults, and the problem is when they come to us as adults, we may not have the whole history from childhood. So when they're adults, they may have fewer seizures, and they may have fewer different types of seizures. The one that specifically stays with them is a tonic seizure, where they just sort of get stiff. And it's very short, and it often happens in sleep. So as they become adults, it's harder to see the seizures because they're not with somebody all the time. And it's harder to diagnose it based on the EEG. So the EEG changes, and they no longer have this generalized slow spike and wave. And I'm going to show you a picture of this also. I know you guys are very excited about the pictures that are coming. So you'll get back EEG reports as a clinician that say multifocal spikes or generalized slowing. The third thing is that they have this cognitive impairment. Most neurological diagnoses, the developmental delay does not worsen over time. It's static, so it stays the same. They have a delay, it doesn't get worse, it doesn't get much better, but it's maintained with use of the therapies and the instruction that they get. But the cognitive impairment in Lennox Gastaut can increase and get worse over time. So why do we need this specific diagnosis? Now, you've heard all the other speakers come up and talk about genetics and identifying genetics early on so that we can treat. So one of the reasons for making a diagnosis is for treatment. And one is for support, and one is so that the family can reach out to other parents and be able to get more information and more support from parents, from the government, from medical professionals. You can also tailor the treatment. So if you're given the diagnosis of Lennox Gastaut, there are specific medications and surgical options that can be used, which may not be available to you if you don't have that diagnosis. All right, so again, this is the continuum over time. So if you look over here at the left, this is childhood, and the other side is adulthood. He's very good at... Oh, I'm sorry. So it's mild, yeah, but it's the continuation over time. So they can have multiple seizure types. They can have many different kinds of seizures, or they can just have a couple of different kinds. And we're going to talk about that. The cognitive impairment can be mild, so that they just need extra help in school, or it can be severe, so that they are in a wheelchair, they can't walk, and they're not talking. And then the EEG can either have the slow spike and wave or not as they get older. And this is the cognitive impairment. Now, this is the DSM-5 classification. So mild is difficulties in learning, immature in social situations, might need some support with complex daily living tasks, so like cooking, bathing. The second level, moderate, is they have some problems with judgment in social situations. They don't rise above an elementary school level, and they need support for the rest of their life in work and their personal life. Severe is they need support in all activities. They can't live alone as they get older, and the spoken language is limited. So they may understand more than they actually say to you. And then the profound is they're dependent in all aspects of care. So this is they need help bathing, they need their food prepared, all aspects of their care has to be taken care of. All right, now we're getting to the EEGs. So now Steve is going to discuss EEGs.
So as Patty mentioned, that there's a classic triad for us to diagnose in childhood this seizure disorder. 1, developmental delay, 2, multiple seizure types, and then 3, what the EEG looks like. And again, remember, Lennox Gastaut is a syndrome. So it has many different causes that contribute to making Lennox Gastaut. Now, you might stop and say, all right, how does this have to do with epilepsy? These kids have epilepsy. So I always tell families, think of epilepsy as like owning a car, all right? And there are many different types of cars, all right? Cars can be, or some kind of automobile. There's cars, then in the cars there's sedans, and then there's sports cars. Lennox Gastaut is the sports cars. But each individual sports car is the cause of the Lennox Gastaut. So for example, one sports car, say the Volkswagen sports car, can be, some genetic disorder. And then the Porsche sports car can be a metabolic disorder. And then American sports car can be brain damage. So all these things can cause Lennox Gastaut. And so that's the problem. But the biggest problem is, over time, one of these triad features, this EEG pattern, this slow spike and wave, which looks like a bunch of pointy things that look like they hurt to sit on, they change as you get older. And on the left side of this, on your right side of the screen, those little pointy things sort of disappear. And that's what happens when you become an adult patient. So you can imagine if you had a patient show up in your office and you're an adult doctor and you have no notes because the paper chart disappeared, and all you saw that was that on the EEG, you wouldn't know that they had Lennox Gastaut. And so the point is, it changes over time, no matter what your etiology or cause of your epilepsy is. So for when we're teaching the residents, we say, look, in children, they have very specific patterns. We mentioned them: generalized slow spike and wave, all these funny little bursts and paroxysmal activity. I'm not going to go through them. But as an adult, we sort of lose these things and they become less funky looking, less unusual looking, less pointy looking, as we like to say. Now, the seizure types, as Patty spoke about before, change over time. So children will do a lot of funny little seizure types that I'm going to show you videos of. They'll do seizures where they drop. They do seizures where they get stiff. They do seizures where everything jerks, rattles, and rolls. But as an adult, a lot of these seizure types will disappear over time, and maybe only the stiffening seizures or maybe the generalized tonic-clonic will be what is left. And so that, again, makes the story look different from when they were a child to when they were an adult. Now, I think if I can get, I don't have a mouse. How do I get these guys to clip it and start it? Oh, there we go. So here's a generalized tonic. You can see the body getting all stiff. And this is sort of a mixed kind of seizure because she did a little bit of a jerk and then a whole body getting stiff. And so this is an example of a child with Lennox Gastaut. And let's go to the next slide. You'll see these again. They'll become more. This is a drop seizure, and you'll see this child walking along. If they could play the video. I don't have any control. Here we go. Push the little arrow. Yep. There we go. And this is an example of a drop. And these are just traumatic kind of seizures, and they can be so severe, or it could just be a subtle head drop. And you really want to learn what type of seizures these patients have and get them under control because they have put them at such risk.
So this type of seizure we really worry about the most because you can have facial injuries. People break their teeth from it. When we see patients coming in who wear helmets, it's because they have this type of atonic seizure where they lose tone and drop. Next slide.
I think this is actually a repeat. Hold on.
Yeah, this is the same one. Next.
Let me go to the next one. Here we go. Now this is another type of drop. It's a little bit more subtle than the girl falling over that you saw standing. And these can be just little head drops, and a lot of families can miss them. They can literally, their face ends up in the soup or in the cereal, and they can be very much more subtle type of seizures, just little drops as well. And sometimes they could just be a quick little jerk. This is going to play in a second. If our folks in audio visual can find the button. Here we go. And you'll see him jerk. That little quick jerk, I don't know if you saw it, but it was just a little quick jerk. That's how subtle they could be. You could be working with them, doing a therapy session or having them write their letters, and they can do a quick little jerk, and those are little seizures, and it wouldn't even look like they're interrupting speaking to you. So this is sort of, we like to call this sort of the potpourri of epilepsy types. They have a whole mixture, a whole bag of different seizure types that can be seen in patients with Lennox Gastaut. Now, the interesting thing is when we talked about the EEG and we talked about all the little spikes and all the little activity, that doesn't mean you're necessarily having a seizure. So spikes were those very pointy things that we saw, you can see up in the corner there in the far right. Those pointy things are spikes. So the analogy we give to families are, imagine a man in the forest with a box of matches. Every time he lights a match, that's equal to the spike that we see on the EEG. Now, most of the time he drops the match to the ground, nothing happens. But every once in a while, he lights off a lot of matches, throws it to the ground, it starts a fire, the fire spreads in the leaves, that's your clinical seizure. So we know what the clinical seizure looks like, but we don't know what all those matches are doing to the brain. And what we're concerned is, even though those matches are going off, we're seeing them on the EEG, we don't see any fires, we don't see any seizures. We know if there's too many matches going off, it affects learning and processing. And so sometimes your medical providers will order EEGs because they want to see how busy the brain is, how many matches are going off, and is that affecting learning and processing. And some of the work that Patty and I have done was looking at these little matches, these little spikes going off when you're asleep, and then looking at how the children do with their learning and memory. And patients with Lennox Gastaut have a lot of spikes going on in their sleep, and they have a real wide variety of learning issues and memory issues. And so sometimes we feel that the spike density, how frequent the spikes are, will interrupt learning and memory and processing. And there's been a lot of great work done in Boston looking at spike density in sleep and how if you quiet it down, because when we sleep, we lay memory. So you know all those nights that you don't get good sleep and your children are keeping you awake and you can't remember what you did the day before? That's because you didn't lay your memory when you were sleeping, or when you were supposed to be sleeping. So the bottom line is we need to sleep, we need to have good sleep, not too many spikes for us to lay memory. And we're sort of trying to learn how to better understand this and why we're always doing EEGs. Now remember, I talked about owning a car, sports cars, and all these individual sports cars are different etiologies. I mentioned if you have damage to your brain from lack of oxygen as a baby, if you have an infection to your brain and it damages your brain, that can cause Lennox Gastaut. If your brain just didn't develop properly, that can cause Lennox Gastaut, and most of those are genetic mutations or possibly toxic exposures that cause a brain not to form properly. We already mentioned the genetic stuff as well as metabolic stuff. And you saw in the beginning of the lecture series here where you saw all these people looking at SOX5 mutations. These are all good examples of gene mutations that don't allow the brain to form properly and cause cerebral malformations, the brain's not to develop properly. So everything you saw before sort of explains why we're talking about what we're talking about now. So here's an example of a baby who is deprived of oxygen and really has significant damage all throughout the brain. And of course, this child developed spasms and has multiple seizure types and is our classic Lennox Gastaut kid. And then this is talking about some of the genetic stuff. And there's been a revolution in the past few years looking at the genetics of epilepsy. And tomorrow, Antonio Gil Najal will be speaking about a lot of these developmental epileptic encephalopathies and some of the possible new treatments for some of these new genetic disorders that are going to be very exciting in how to prevent epilepsy and help improve development. And then this is an example of some of these genetic disorders that cause metabolic disorders. And again, this is a whole new world of genetics, and these things are actually treatable now that we're finding from genetic testing, these metabolic disorders that now we can actually treat and change the direction of the child's development, which has been very exciting in the past 5 years. So what have we learned? So as far as in the past, in 1975, really 3/4 of what caused kids to have epilepsy was what was called idiopathic. And in America, we call that we're idiots because we don't know why these kids have epilepsy. I know in Spain, nobody is one, so. But now we know that 3/4 of the patients really have some genetic underlying problem. So, you want to talk about?
Okay, so as I said earlier, the problem is best treatment options. So that's why the workup now, the workup used to be that you would do an EEG and you would start treating the child for the seizures. Now we do genetics early on, we do the EEG, and we do an MRI. So we look at the structure and the function of the brain and also look at genetics to see if there's some cause. So what happens, though, as they grow into adulthood, and many of the patients that we see now, their parents are dead, they're living in a group home, and nobody knows what the history is. So we have a difficult time deciding whether they meet the criteria for Lennox Gastaut. And then the problem in the United States has been historically that when new medications come out, it is difficult to get insurance or the government to pay for the new medications or the new treatments. So we started identifying people with Lennox Gastaut earlier on, which we hadn't done in adulthood so much before, so that we could get new treatment options. What happens is that you end up seeing these patients, and adulthood can start, these patients are not necessarily old. They can be 26, 27, all the way up into their 70s. But they will come to us on many, many different medications, some of them on 7 or 8 medications with no quality of life. So they're sleeping all the time, my favorite is when they're on so many medications that their whole day is spent taking medicine. So someone is following around them, and every half an hour to an hour they get a different medication. Also because no one has ever said you can take the medication at the same time. So the difficulty with identifying Lennox Gastaut in adulthood is we don't think of it, not we, but people in general don't think of it. The seizures type change. So those children who are having the drop seizures or having the generalized tonic-clonic seizures may no longer have them, and all they have is those tonic seizures where they just get stiff, and it's very quick, and it's often missed. And again, the EEG changes. So for a person who is not treating epilepsy all the time, a general neurologist, they may not think to do an overnight EEG to capture the abnormalities. So about 50 to 75% of the children who had LGS no longer meet all the criteria of the childhood, I did really mean to, but that's okay, of the childhood diagnostic criteria. So again, the young children have multiple seizure types, the EEG changes, and the problem is, as I said, it's not diagnosed in adulthood. So if somebody presents to us as a new adult that we've never seen before and they change providers, you don't have the history. When we used to have those handwritten charts, the handwritten chart would follow them around. And by the time they would come to an epileptologist at the age of 40, the chart was this thick and nobody was going to read the entire chart. Now we have electronic medical records, which typically are missing a lot of the information because it was never put in the first place. So the history's not available, we don't make the diagnosis, and we have limited access to state-of-the-art options. So in 2016, 2017, a bunch of us got together, a group from the University of Pennsylvania, a group from Nashville, and then Steve and I, and we set out to make a tool that it would be easier to diagnose Lennox Gastaut syndrome for people who are not familiar with it. So we sat down and we created this epilepsy, it's called the Refractory Epilepsy Screening Tool for Lennox Gastaut syndrome. So as I said, we got together and we decided what were the most important things to look for and how could we tell if the patient met the criteria, if we had very limited information. And we, in many rounds of talks and brainstorming, we came up with a specific criteria. So we decided that all of these were important criteria to think about. So cognitive impairment, obviously, multiple seizure types, seizure onset less than 8 years of age. Now, in an adult, that's often hard to find out because maybe you have someone from the group home, or maybe you have a sibling. And if you have a sibling of that adult patient, you can say to them, when did John start having seizures? And they'll say, oh, back when he was a little kid. So that helps. Frequent use of emergency room or clinic visits. So they're seen very regularly. These are not people who come in once a year for a doctor's appointment. And then the things that were very significant to us were the people, as I said, the people of the atonic or the drop seizures, they wear helmets. So someone who came in wearing a helmet, if you could ask, is that because they're having seizures, or is that because they are hitting themselves in the head? And if it was seizures, you could pretty much tell that they met the criteria for Lennox Gastaut. Then we also asked about what kind of history they had in terms of treatment of their seizures. So if they had had specific surgical interventions, a vagal nerve stimulator, which is a pacemaker, a resection of part of the brain, or a corpus callosotomy, that made it more likely that they had this very intractable epilepsy for their whole lives, because people don't typically get to epilepsy surgery, at least in the past, until they had refractory epilepsy. So corpus callosotomy is specifically used for drop seizures, and it severs the two sides of the brain, so the drop seizures are less frequent. And then also if they had an identifiable etiology or cause, and this is where the genetics comes in. So if they had Dravet syndrome, hypoxic ischemic encephalopathy, metabolic disorders, Dravet syndrome, tuberous sclerosis, it would be more likely that they were that their diagnosis was consistent with LGS. And this is the tool that we created.
So I'm not going to torture you with the details, but what was the point of doing and making this short questionnaire? Was Patty and I were giving lectures around the United States to adult neurologists talking about new drugs that were for Lennox Gastaut. And I asked them to raise their hands how many people had patients with Lennox Gastaut, and literally 3/4 of the room did not raise their hand. They said, oh, it's a childhood disease. And that was when we had the oh my thought process of we need to educate and come up with a better tool so they can make the diagnosis better and easier and allow treatment. So then we also realized it sounded like, oh, this should be easy, but we had to make the tool so short and so easy to use that A, anybody could do it, B, you only had to look at the last 3 notes, because we found out that most medical providers only go back and look at the last 3 visits. They very rarely look at the big chart, and if it's an electronic medical records, they don't go back at all. So we really had to make it very simple. So they're really just yes, no, or unavailable questions. And you've already heard us, repeat these different seizure types, multiple meds, seizure onset before the age of 12, helmet or facial injuries, cognitive impairment, any kind of surgery, diet, the abnormal EEG pattern that you keep hearing us say it disappears, and then some other EEG pattern, and then we score it. On the left side is all the statistical analysis, because to try to make a rating scale be significant, we had to get a biostatistician to really work at it. We had to do hundreds of people to try to make it significant, and that's some of the work that we've done here. And these are all these scary scales and ratings that we had to do to justify and prove that we can look at people who just have bad seizures versus patients who have Lennox Gastaut. And then this is just sort of breaking down which of the subcategories was really important. So those of you who are really excited into this will be glad to talk about it, but we want to get you to lunch. And then what we did is a few years later, we took our tool and we went into group homes. So in America, we have these large residences where many of these patients with epilepsy live because they can no longer live with their families. And we found that we have a lot of patients with epilepsy there, but they don't have a clear diagnosis. They're just labeled as bad seizures. And so Patty and myself went and we did over 200 patients, and we went and tested to see if we could pick up patients who weren't labeled properly and if they weren't on the right medication. So we just finished this and we're publishing this next month. And we did the same thing. We asked the doctors and the medical providers in those residences to look at the patient's last few notes, see if they meet any of these criteria, and check off the box of yes or no. And then we went through what was the most significant of the number of patients that we did. This is just looking at all the different abnormalities on our questionnaire. And then here's our questionnaire. But this time we actually were able to give a scale. So if you look at the very bottom, if you have greater than 11 points, you're very likely to have Lennox Gastaut. If you have only 8 to 11, you probably have Lennox Gastaut, or possibly. And if you had less than 8, you are unlikely to have Lennox Gastaut. So now we've done enough patients with this rating scale that we're able to give the score and then tell the medical provider yes or no, should they be thinking about this syndrome with their patients with very limited information. And so basically what did we find? We found that when we did our 100 patients in this last study, if you look to the left, we found, I'm sorry, you're right, apologize. When you look to the right, we found 42 patients that were undiagnosed with Lennox Gastaut that probably have Lennox Gastaut, and they need a further evaluation so we can clarify whether they really have Lennox Gastaut and are they eligible for new medications and new treatments. So that was really the whole point of this, and to us, this was very successful in these group homes, and the medical providers said to us, great, they're still having seizures, now I can do something else. So basically the potential benefits, as I pass back to the smarter half here.
So just to reiterate, so what we did is we got a bunch of experts together, we tested the scale in 2 different large medical systems, got inter-rater reliability, and then several years later we used it in the real world and had medical providers who were not neurologists. Well, one was a neurologist, one was a medical doctor, the director of the group home, and tested it in the real world to see if it was useful and if they can make the diagnosis. And what happened with those 42 patients is that they were then sent on for a further evaluation. So they were sent to a medical center with an epilepsy program so that they could get longer EEGs, which are difficult to do in this population, and then have access to newer medications and other treatments. And as I was saying to somebody outside, these people come in and they're on a bunch of meds, they're sleeping all the time, there's no quality of life. So at least if we get them another assessment, you can sort of make the meds a little simpler and then slowly get them off some of the meds and add on something else that might be more effective. So the reason that we want to identify it is for that reason, for quality of life, for decreasing the seizure frequency, so they have fewer seizures, fewer side effects from the meds. They're not falling because they're not having so many seizures, better quality of life, and fewer problems with walking and motor issues. So again, often missed in the adult population. We can use this tool for identification. And again, it's a complex relationship. I was also saying to someone earlier that the good thing about the pandemic is that we switched early on to telemedicine, at least in the States. And we used to have people coming into us from some of the adult programs, or with their parents or their siblings. It could be with the family, or it could be from a group home. And the person who was with them really didn't know much about the patient because they were doing overtime. They didn't have the availability of transportation. And, you would often wonder what went on in the house. And now what we're able to do with telemedicine is we can zoom directly into that group home and we can see the people who really know what's going on with this patient. We also physically go to some of these places, but the big thing is that you can see that the group homes are not sort of as bad as we thought they were in the past, that the people who care for them are, for the most part, loving providers who really want to make life better for them. And that's an important point. So these are some of the new treatment options, and not all of them are new. A lot of them have been around for a long time, but there are refinamide, clobazam, Epidiolex, cannabidiol, fenfluramine. There's 2 new trials going on. But specifically, if you go to, if you see some of these adults, the person who's taking care of them may never have thought of meds that have been around for a long time, like clobazam and refinamide and cannabidiol. It just didn't even occur to them. And then there's the surgical techniques that I talked about, corpus callosotomy, vagal nerve stimulator, and then NeuroPace, which is a responsive neurostimulator that we spoke about last year, that you can use bilateral thalamic implantation for these patients, also a deep brain stimulator. So we're using that more and more in the States. This is the newest criteria for diagnoses of the childhood developmental epileptic encephalopathies.
Don't try to read it.
It's a little blurry because I just put it in. But so this is the International League Against Epilepsy. So they just recategorized all of the childhood epilepsies. The ones that we're interested in are the ones on your right, the developmental epileptic encephalopathies. So we have Lennox Gastaut, and then under that we have a grouping called developmental epileptic encephalopathies with spike and wave activation in sleep. So that's Landau-Kleffner, it's ESES, and pseudo-Lennox syndrome. And then there are the ones that start with infection, so fires. These start with an encephalitis or a meningitis, and they become very intractable epilepsy. And then these hemiconvulsive, hemiplegic epilepsies. So what we need to do, and not just in Spain, but everywhere, is we need to so identify people with these syndromes and use the correct diagnostic criteria. So instead of people walking in and having their diagnosis be seizure disorder or seizures or other seizures, if you use the right words to describe it, then we have a more accurate count of how many people have that specific diagnosis. And then we were able to get more treatment options, more funding, more care for these patients. So it's important, even though it's hard to read, it's important to use those correct diagnoses and the correct genetic etiologies for them.
And please come tomorrow because Antonio will discuss these more.
In depth.
Our friend and favorite child neurologist.
Not favorite.
One of our favorite child
One of our
neurologists.
favorite.
In Madrid. Well, she's not in Madrid. She's in
Yeah.
Valencia.
In Spain.
You know, I didn't say Spain. But please come and listen more about that tomorrow.
And I think that's the last slide.
So thank you
So
very
thank
much.
you.
I hope that was helpful.
Any questions for us?
So has something to do with Lennox Gastaut with Landau-Kleffner?
No, it's
all
another.
About, it's all about syndromes. That they're all in this whole world of syndromes.
It's a developmental epileptic encephalopathy. It's the
Uh,
same broad
hello.
category.
I have two questions. The first one is there a difference or a higher predisposition for Lennox Gastaut in lower income communities? And the second one is, would you say that the healthcare system in the U.S. is part of the problem in confirming or getting to the diagnosis of Lennox Gastaut?
Good question. So as far as socioeconomic for Lennox Gastaut, the answer is no. It seems to be across the whole spectrum. It's more related to. I don't think you can give it a singular answer.
None of the epilepsies have any prevalence in socioeconomic. However, the failure to treat, so undiagnosed infantile spasms, may be related to access to health care, and most likely is. And we can, from our very own experience, show that a delay in getting to health care because there's problems with access, or there's problems with, well, access meaning money, language, appointments, resources, is a problem. And that, so I guess indirectly, undiagnosed infantile spasms will lead to a more frequent diagnosis of Lennox Gastaut.
But even diagnoses can be delayed even in America. So we had a good
the time.
example of a family that went to the ER twice in America with a child with spasms. They weren't diagnosed. The family sent a video back to Ecuador. A doctor in Ecuador said, it looks like infantile spasms, and then they came back to the ER again and finally was diagnosed with spasms. So the Ecuadorian doctor made the diagnosis.
She's from Ecuador. No, the second, we didn't answer the second. So the second question is the health system in the United States problematic? Yeah, because of access. So that specific child went to a local community hospital, then went to a large hospital system, a very good hospital system, and was misdiagnosed at both. The problem is that if we're not getting the education down to the people who meet you in the emergency room or to the pediatricians or whomever the provider is, and they don't know to so identify it as a seizure, there can be a delay. So it's an educational problem, right, as well as not having insurance. But in the United States, even if you don't have insurance and you present, you should be treated. Yes.
So thank you very much, and I think the previous question links to mine. Do you think the REST LGS tool has to be performed by someone who has the education, an epileptologist, general neurologist, or even primary care?
We developed it. The first round was the people who scored it were a medical student with no neuro or epilepsy experience and a nurse. So yeah, no, the idea is that anybody can fill this out. Anybody in healthcare can fill it out. And that's the group that we want to get to. It's not, the epileptologists know how to do this. We know how to diagnose it. I'm not an epileptologist, but the epilepsy people. But it's the people out in the community who may not be attending the big meetings, may not be getting the latest information, that don't know to diagnose.
And how would an epileptologist meet if they come with a REST LGS tool with a 11 point, and they tell them, I think I have LGS because they have performed this at another setting? How would this be?
How would it change treatment?
Or how would this be perceived by the different
epileptologist?
Yes.
I think
Great work. Thank you for sending them.
Yeah, I think we really appreciate when someone comes in diagnosed. I don't think anybody would be offended because it's really a history. But your question is good because there's such a limit of information. If a family member can talk to a social worker and they can fill it out together and get the old history, that would help. If it's the nurse talking to the family or the medical provider, that's why it's designed so anybody can help make the diagnosis, because basically we're lacking diagnoses.
Okay, good morning. Very beautiful. Thank you very much. So my question is going to be very basic, probably because I lose the information because I was a little bit delayed, but anyway, probably is that. So the question is, finally you can establish different categories of epileptic, not very easy, very complex epilepsies, syndromes. So the question is, Lennox Gastaut and the other categories are in relation with the gravity of the alteration in brain function. So there is a graduation in which you are worse brain function, you have one diagnosed than the others. Or in another side of this question, is any biomarker, localization, complexity of brain malformation, or whatever, or toxicity, in which you are going to buy a sport car instead of a camion? So you have some morphological criteria, some ideas by which the brain react to one toxic or one malformation or one malfunction in one way or in the others?
So I think your question is brilliant, and it's the point of the word syndrome is not what we should be studying. It should be studying each individual sports car, which is each genetic disorder, each underlying problem, to better understand and better decide how to treat that child. And so right now, many years ago, our doctors and medical providers weren't smart enough to tell you what was each individual sports car. They could just tell you you had a sports car. So I think our future is trying to get smarter and get down to the exact disorder. And then with the research that you guys are doing, whether it's a SOX5 or something, we'll be able to treat that. And we're not there yet, but we're getting there yet. So we have to learn to teach everybody to recognize the disorder, and then we can start getting down to the etiology, and then hopefully the treatments. So we're trying to get smarter. But what we found was we weren't diagnosing it. Yeah.
I have also a question for you. Given the new, not that new, epilepsy classification by ILA, whatever, do you think that it is better for clinicians, or it's such a confusing thing sometimes? Because I feel, mostly in a country like yours, in which the number of the classification is so important to get some money to get, is it? So I think it's confusing for a clinician. It's pretty well for all those things you've been telling about, but for a clinician, what will be your advice?
Because if not in Ecuador, it's going to do better.
Right. So the bottom line is this classification where they try to make it much more specific to what the EEG looks like, what the seizure looks like, what the underlying disorder. I think it is confusing, but I think in the long run, when it comes down to treatment, it will be useful. So it is a huge amount of vocabulary we have to learn, but it will be useful. And it's painful. Yes.
Thank you for the practical.